Hi there, I'm Ranil Chandra, Head of Stroke Imaging, Endovascular Clot Retrieval, and the Neurointerventional Radiology Service at Monash Health. Today, we're here to talk about the code stroke procedure. Code stroke is a clinical pathway designed to facilitate rapid assessment and treatment of stroke patients arriving to Monash Health. Early diagnosis and reperfusion treatment saves lives and reduces disability. For every 15 minutes that we save to intravenous thrombolysis, the patient gains an extra 1 month of healthy life. For every 15 minutes that we save to endovascular clot retrieval, the patient gains an extra 2 months of healthy life. The purpose of the code stroke procedure is to rapidly identify patients who are eligible for reperfusion treatment. The code stroke procedure is activated when the patient fulfills certain clinical and time-based criteria. Within 6 hours from last seen well, the patient is included if they have any neurological deficit, including those that are rapidly resolving. Between 6 and 24 hours, patients are included if they have persistent or fluctuating symptoms. Patients are included when they have good baseline functional status. For example, a patient should be able to walk from one room to another room without the assistance of another person. After code stroke activation, the patient is rapidly assessed by the stroke team. They're taken to the CT scanner, which is being prepared by the CT radiographers. Our standard code stroke imaging protocol includes a non-contrast CT brain, CT perfusion, CT angiogram from aortic arch to vertex, and post-contrast CT brain. Each of these scans is important. Each one of them help with diagnosis and management. So now let's move to the reporting room where we can talk about the purpose of each of these scans. Our first scan is the non-contrast CT brain. The main purpose of this scan is to identify if there's intracranial hemorrhage as a cause of the patient's symptoms. If there is hemorrhage, then the management pathway changes as the patient is not eligible for reperfusion therapy. Next is the CT perfusion. We use this to rapidly make the diagnosis of ischemic stroke. If there is a perfusion abnormality corresponding to a vascular territory that matches the patient's clinical symptoms, then the patient is having a stroke. We also use the CT perfusion to rapidly identify the site of vessel occlusion. This is based on the known vascular topography of the brain. This also helps stratify the management decision as patients with large vessel occlusions are treated with endovascular clot retrieval. We then use the CT angiogram for 3 main reasons. Firstly, to confirm the site of occlusion as suspected on the CT perfusion, to assess the access for potential endovascular clot retrieval, and finally, to assess for potential causes of stroke, such as atherosclerotic disease or arterial dissection. Our final scan is a post-contrast CT. This is helpful in identifying areas of abnormal contrast enhancement that may occur in subacute stroke or stroke mimics such as brain tumors. Now, an important question to answer is whether there is brain tissue to save. This is because reperfusion therapy such as intravenous thrombolysis or endovascular clot retrieval are targeted at restoring function by saving brain tissue. The distinction between predicted infarcted and salvageable brain tissue is made using a combination of the non-contrast CT, CT perfusion, and post-contrast CT. For many patients, the code stroke procedure is where their stroke journey at Monash Health begins. As we progress through our teaching series, you will learn more about stroke imaging. Fortunately, at Monash Health, we have an experienced multidisciplinary team that helps many patients return back to their families.